Taking care of my mind, body, and soul.
For me, self-care means community care.
I practice self-care by regular breast self-examination.
I practice self-care by creating or joining spaces that allow me to express myself.
Self-care is all about prioritizing me time.
I practice self-care by choosing to use a long-term birth control called an IUD to prevent pregnancy.
Hello, I'm Christy Cade with the White Ribbon Alliance.
And I'm Cindy Garcon, Coalition Director of the Self-Care Trailblazer Group. We are thrilled to welcome you to the Self-Care Learning and Discovery Series. We are a global coalition dedicated to ensuring everyone practices self-care. We advance self-care advocacy, evidence, practice, and learning to support people meeting their own health goals and to strengthen health systems.
The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. The series has invited more than 50 organizers from around the world to share what self-care means to them in practice through 16 individual sessions. While each session examines self-care through a unique lens, they are very much connected. We encourage you to participate in as many as possible.
The Discovery Series is open to everyone, advocates and activists, healthcare providers, government officials, program implementers, community members, because all of us should have a vested interest in self-care. We hope you share your own ideas and insights throughout the series and keep the conversation going by becoming a member of the Self-Care Trailblazer Group. We'd like to thank the members of the Self-Care Learning and Discovery Series Steering Committee, Advanced Family Planning, JPIGO, PATH, Population Services International, and most of all, White Ribbon Alliance. Without you, this learning opportunity would not be possible.
We also want to thank all of the session organizers who have dedicated their time voluntarily to curate this event. We should also say that each of the organizers took on the responsibility of the content in individual sessions, and so they might not necessarily reflect the views of the steering committee. Please take what you learned today and apply it to advancing policies, programs, and practices that enable self-care, universal health coverage, and your own individual health and well-being. Now, without further ado, we turn it over to today's session organizers. Thank you.
Thank you and enjoy.
Welcome, everybody, to this self-care session on Know Thyself, Behavioral Insights into Self-Care Decision-Making and Empowerment. First, this is an interactive session where you have a number of engagement opportunities lined up for you. In this Know Thyself session, we take a deep dive into understanding the perspectives and needs and challenges of distinct populations across Africa and Asia. Those include youth, women, special needs populations, and the elderly. Our big question in this session is, how do people make decisions around self-care? And what is the relationship between self-care, decisions, and empowerment? Before we begin, we will first invite you to participate in the first interactive session, where we want you to actually take a short poll on this. But allow me, first of all, to just share a few slides on this particular session in terms of the modalities that will be shared during the session. So tech team, take over.
Yes, so just to announce for everyone, we have interpretation services available. So if you would like to listen to the session in French or Spanish, please select the interpretation option at the bottom of your screen. Click the little icon that looks like a globe and select the language channel of your choice. And so as Sylvia mentioned, we have a poll for you all. There is a link in the chat to go to the next slide. We would like to ask you all in one word, what does self-care mean to you? If you have any problems with the poll, because we'll have many polls today, please let me know in the chat.
Thank you, Natalia. And what is so interesting about this poll is that it's a word cloud. So please just try your best to minimize your responses, and let's see the kind of responses that you generate. So you can click on the link that has been generated on the chat box and start letting us know what self-care means to you. Meanwhile, I can see people popping: liberation, empowerment. I love that. So what makes this session unique? What makes it unique is the appreciation of social behavioral change as one of the key approaches used in self-care programming, and the subsequent need for various conceptual models, approaches, and framework to drive behavior change. And we have broken down this session into 4 very interesting panels. And these panels are going to be broken down into 2 sessions. The first particular session will focus on community perspectives on self-care and reproductive empowerment and self-care. The next 2 panels will be on behavior journeys in self-care. And the last panel will be on behavioral insights into self-management versus provider care. My name is Sylvia Wamugiobaga, and I'm the Deputy Director of Advocacy, Communications, and Strategic Partnerships at WIACT Youth in Action. That's basically a regional initiative by AMREF Health Africa that focuses on giving the voice, skills, and capacity to young people to be able to advance youth policy priorities specific to their SRHR and gender equality needs. Before we delve deeper into this panel presentations, a few rules. So first rule, Of course, mute your mic during the session. The second rule, we encourage you to participate. Please use the chat feature on Zoom. And while you use the chat feature to ask any questions or any concerns or even have comments, please use the chat feature and put in the country you're from and also your name. After each of the panel presentations, we will have 2 panel presentations, and after each of the panel presentations, we will have breakout rooms where you get an opportunity to actually interact with the panel presenters and also ask questions where need be. We also have a number of interesting exercises during these panels, during these breakout rooms, where you get to engage a bit more deeply as participants and with one another. The first 2 panels, interestingly, take us to Africa, where we look at community perspectives on self-care and a growing concept called reproductive empowerment. We examine experiences and studies from Nigeria, Eswatini, and Uganda that should inform our programming around self-care. Now, I will not say much. Allow me to introduce the first and second panels. The first panel will focus on community perspectives on self-care, and the second panel delves into the influence of self-care on reproductive empowerment. This panel is actually led by Christy Asala. Christy is a dynamic advocate and communications professional with more than 11 years experience working in the field of sexual, reproductive, maternal, newborn, child, and adolescent health in more than 15 states in Nigeria. She currently serves as a national coordinator for the White Ribbon Alliance in Nigeria. The next panel will be led by Dr. Erick, who is a youth, sexual, and reproductive health and rights specialist based in ICRW Africa office, and he has experience in research, monitoring, and evaluation on women economic empowerment and SRHR in Africa. He brings over 15 years experience in managing, designing, and implementing monitoring and evaluation systems and framework. So a very warm welcome to the first panel that is being led by Christy Asala. Welcome, Christy.
Thank you so much, Sylvia. Go straight to the point. Nigeria has made significant progress on self-care guideline for SRHR Health, who have taken the lead on self-care in all our interactions with stakeholders. This feedback cuts across different casts to healthcare providers, to people in the community, and that is, a concern of the huge gap of health illiteracy in Nigeria. And how do we actually trust the community to practice self-care? Secondly, was of course, how do we effectively reach the different groups in the community, considering the population of Nigeria, and also how do we address myth and misconception, around self-care products to enable us to improve access. Now, this challenge is not peculiar to Nigeria, but other several low and middle income countries like Eswatini, which we'll be hearing from shortly. So the White Ribbon Alliance Nigeria, in collaboration with JSI, World Health Organization, and Pathfinder International, set out to conduct an assessment on what self-care means to different rights holders groups, to provide a behavioral insights to community perspective on self-care, of course, existing self-care practices, barriers to access, sources of information, and this will hopefully enable us, develop a comprehensive strategy to build health literacy and, of course, generate demand for self-care. Now, the preliminary findings, were a great learning for us, and also reset our earlier thoughts and strategy on how to implement self-care in Nigeria. In this panel today, we will be sharing the preliminary findings from the study, which was widely disseminated around 6 geopolitical zones in Nigeria, covering 160 communities, and of course, with over 400 responses. And so I will just share an overview of the preliminary findings. Next slide. Next slide, please. All right, next slide. All right, so the study was a cross-sectional, assessment involving self-administer to, and a number of internally displaced people accounting to 1.7% from 2 conflict states in Nigeria participated. And of course, we also had media responses. The respondents were mostly female with 91%. And of course, participants ranged from 25 years and above, and they were mostly from the rural setting in Nigeria. 80% were married, and we actually had more responses from women and girls, and also had responses from elderly, people living with disability, and of migrants. Next slide. All right, so the next slide actually, looked at an open-ended question we asked. We wanted to know what self-care meant to these different groups. There were a lot of responses, but I will just focus on the top 7. So most respondents said self-care basically meant taking care of oneself, and other people added, without the supervision of a healthcare provider. We also had responses as self-care, is taking responsibility for your health, ability of individual to prevent disease, state of well-being. Other people said body and food hygiene. And we also had a number of people that are actually able to define self-care using the WHO definition, which was quite impressive. Next slide. Yeah, so we had a whole lot of responses, but I will just skip because of time. Next slide, please. Yeah, so we also wanted to know the number of respondents that practice self-care. And a whopping 90.7% of respondents here, they actually practice one form of self-care, or the other. And in the next slide, please, we'll be looking at the self-care products they actually use. Malaria self-diagnostic kits came as the top product from respondents with 41.1%. That was quite shocking for us because we would think DMPA and SC would actually be one of the most used products. We have condom and lubricants with a 3.9%. DMPA SC was at 2.7%. HIV self-test, 29.5%. Pregnancy self-test, oral contraceptive pill, and ovulation predictor kits were actually other top self-care products used. We also had other self-care product people also use, the mentioned menstrual hygiene, breast examination, and so forth. But we just highlighted the top responses. Next slide, please. So we also wanted to know where people get their self-care products from, and health facility came as a top, which was 53.1%. Now, this already tells us, where we should be basically putting our efforts, on sensitization. From pharmacy, 24.6%. People that got from patent medicine store was 9.5%, and also NGOs, 9.5%. Next slide. All right, so we also wanted to know passive benefits, of self-care, which I really would not, bore us with a lot of that, but it was interesting to know that, most of the respondents actually felt self-care has a huge benefit, on people, and if they have to practice self-care, they would prefer, to do that rather than running to the health facility. There were a lot of barriers, having to access health facility in a lot of communities in Nigeria. Next slide. Yeah, I think I'll skip those two. Yeah, so the next slide looks at, we're looking at, what are the predictors of self-care, basically what will make people decide, to practice self-care more in the country. And most respondents said, information of available products. And others also said, education on the proper use will give them more confidence, to want to practice self-care. And of course, availability of funds, is also a major predictor. And community support, this was really stressed by most respondents, that if they have support from their community and peer group, they would easily be able to practice self-care. We also wanted to know the sources of information for most respondents, which I mean is going to be the pillar of health literacy for us in Nigeria, and health outreaches. People actually get information from health outreaches, accounts to 62.9% of respondents. Community dialogues, 61.8%. Face-to-face was at 4.7%. Now, radio, which we thought would be to top the list, was 32%. And most people that actually said radio will say they still want to get information from health outreaches, even after listening to radio. And television was 19.3%. I will be handing over right now to my colleague, Dr. Adewole, who will be taking us through barrier to access, as we saw from the responses. Dr. Adewole Adefalu works as Nigerian DMPA Access Collaborative Country Coordinator with GSI, supporting the FMOH to coordinate stakeholders' collaborative efforts to introduce the next generation of FP method, DMPA, into the reproductive health commodity supply. Adewole is a physician with over 18 years progressive incremental experience working with multidisciplinary teams to carry out diverse ranges of public health interventions on research, project management, health system, and capacity building at the community and national levels. Over to you, Dr. Wale.
If you're speaking, you may be muted, just letting you know. We might need to ask you to connect your audio. Unfortunately, cannot hear you right now.
Hi, everyone. Can you hear me now?
Yes, we can.
Yeah, sorry for that. And thank you, Christy. I was saying I'll be talking about the barriers to access for self-care and lessons we learned from DMPA's introduction in Nigeria based on the study which Christy just described. Can I have my slide on, please? Great, thank you. So maybe you move to the third slide. The government of Nigeria moved from development of our national guideline to the phase where we had this quick rollout of subnational engagement for implementation of self-care. Next slide. We had that conventional thought about how do we move from developing a guideline to actual implementation. And the first place we started was to look at engaging subnational actors across 13 of the states and in all the regions of Nigeria. These supports for the Ministry of Health came from the Access Collaborative Project of GSI, collaboration to GSI and PATH, White Tribune Alliance, Pathfinder International, Share for Reproductive and Family. This entire activity was planned in such a way that the first day is a high-level advocacy to top decision makers at the state level, particularly the health sector, targeting the health sector and Primary Healthcare Development Agency, which is responsible for human resource in the public sector in Nigeria. The second day or next 2 days, depending on the size of the state, involves the sub-national actors in the public sector, FP managers, as well as other participants, where we take them through an orientation on what self-care is. And we use that same medium to also give them a chance to look at the data they've been submitting on the DMPA. So the mix of the participants were government and state level stakeholders, civil society organizations, vulnerable groups like sex workers, people living with HIV, and people who inject drugs. We also targeted public and private sector providers, including pharmacies, patent medicine sellers, or drugstores, as we call them in some of our countries, professional associations and regulatory bodies, as well as women groups, were all involved in this orientation. Next slide. So the entire activity was to look at some of the issues around health literacy for self-care, like Christy had described. But within the sector, to know, are there barriers that we have to self-care implementation, so that this will help to guide the government in taking a decision. Some of the very interesting findings we got was that most of the responses around these barriers were like centered around about three things: poor knowledge, fear of products availability, cultural barriers, and some of the myths about self-care products, which may impede successful implementation in Nigeria. These are some of the responses from providers. A few of the respondents talked broadly about the need for more awareness about reason about self-care, particularly among clients who will need these products. But more importantly, we also found that particularly at the community level, there were a lot of responses stating the fact that there's a need to raise awareness to remove this barriers. Some providers noted concerns with ability to talk to clients because they felt that they were not proficient enough in some of the different self-care products to be able to counsel or actually administer those products to families or women. And some interesting things I found, things we found from that study are what I put in these boxes. The first one there was a male community member in Enugu State in the southeast in Nigeria. It says that I fear addiction, failure to attend the health facility as well. There's no knowledge of updates in the self-care policy. Putting all of this together, one will see that this individual is beginning to think that will self-care also mean self-medication? And would this also breach the do no harm principle by people going the extent of addiction with some of the products that are under the self-care portfolio? Then there's also the fear of people moving outside of the traditional health facility and not having access to quality advice by providers. This was a recurring theme across all of the responses that we got. Secondly was a provider in Gombe State who said there will be barriers. I expressed a fear that there will be barriers in accessing kits as well as stock out of commodities. I'm sure this is premised on the experiences they've had with family planning products, which sometimes they have these erratic supplies, and she's already beginning to think forward about having the same challenges with self-care products in Nigeria. Thirdly was a young woman in Bauchi State who said, my husband doesn't see the importance of family planning. I'm also not aware of anything about self-care. So this all speaks towards, as much as people would want to get involved in self-care, there's a need to increase awareness. Awareness will help a lot to overcome some of the barriers or these discussions that we have identified. Next slide. So we want to also share some experience from the DMPA's introduction, which is also a portfolio of product under self-care. Next slide. In Nigeria, the product was introduced in 2017, and some of the experiences we've had is how much this product introduction influences the health system in such a way that systemic changes happen often, and there's a need for removal of some of these bottlenecks that may impede product introduction. I think for DMPSC, essentially, there were a few areas of consideration, but key amongst them was the fact that the government had highlighted the fact that they wanted a total market approach to this product, and they believe that self-injection can dramatically expand access and choice for women, hence reduce the burden on the health system. But more importantly, also deploying DMPSC throughout the identified public, private, and community service delivery channels was seen as a means to maximizing service uptake. Next slide. So sharing some of the experience from Nigeria, the UNFPA program delivered DMPSC outside of facility through proactive community-based distribution and was effective in reaching particularly underserved women. This community approach to programming was very helpful from some of the results that have been reported in reaching these underserved populations. Among the strategies that were used in the area was in the area of where they have conservative cultural norms, they had to employ strategies like door-to-door outreach or outreaches, enabling women who may have or face some restriction in leaving their homes to access DMPSC. This is one of the laudable things that we should explore through community intervention for self-care, because this direct reach out to individuals in their community, in their milieu, is an opportunity for them to actually have access to these products. Community resource persons we found in Nigeria were the main source of self-injection. And between November 2020 to date, we found out that there's been a skewed number of women taking products more from these community groups compared to the facility group. I took statistics from November to around May. More than 2,000, almost 2,500 women received services from CBDs compared to 1,500 women who took service from community-based providers in 5 states. Next slide. So what did we learn? We learned that there are variations you will find across geographies. In Nigeria, we found out that there were some areas where we had high performance, where some were lower. Special strategies like engaging young people would involve hearing from them, screening providers to exclude those biases against youth, and recruiting even younger volunteers to assist with outreach and distribution of products. We found a little bit of challenge, often difficulty with collecting data from community service delivery points. But we found that digital platforms was a veritable tool to reach young people. There was a high response to increasing amount of inquiries from people who were seeking SRH information, and they were able to access services through these means. Communication channels have also been especially popular among young people on the DMPA rollout. Next slide. So what are next steps for us as a country? Collectively, the government is looking towards further engagement with states to ensure they prioritize the commitments to roll out. On this current caravan, which we are doing across the states, we found a lot of commitments from these high decision makers, policy makers, and following up on those, one of the priorities for the Federal Ministry of Health. We're also hoping that partners and donors will support this rollout going forward, as this will ensure the needed traction to achieve implementation at scale. Supporting countries to develop appropriate data use approaches would also be helpful, but more importantly, continuing to adopt and adapt and advance innovative training methods that would reduce costs will also be helpful to many of our countries. We're also looking at within the country in the coming months to developing strategic behavior change materials, which are low-hanging fruit opportunity for us to help states to effectively roll out demand generation and behavior change interventions for self-care in Nigeria. Thank you so much for your attention. I would be quickly handing over to my colleague, Yusuf Tukrunu, a program officer with Pathfinder International. Yusuf is a reproductive family health program officer. Pathfinder International, as we know, under the Advanced Family Planning Projects, since 2018 has been working to support implementing advocacy for increasing investment and political commitments to increase access to information services and supplies. Prior to Yusuf's current position, Yusuf had worked as a technical manager, evidence and accountability at Africa Health Budget Network, leading to the implementation of advocacy strategies in health budgets and policy advocacy for family planning, immunization, maternal and newborn child health, and CSO engagement for implementation of Nigeria RMNCAH strategy. He has also worked as a monitoring and evaluation officer for Issa Wali Empowerment Initiative, providing technical support for implementation of projects in family planning, girl child education, and girl women rights empowerment. He has experience in advocacy, community mobilization, citizen engagement, M&E, and capacity building. Thank you so much, Yusuf, and welcome.
Good morning, good afternoon, good evening, everyone. Thank you very much, Dr. Adefalu. Like we all know, self-care is multifaceted, multidimensional, involving broad stakeholders as well as subject to different kind of influences. On this presentation, I'll be looking at the perspective of healthcare providers on self-care, following on what Christy earlier presented. That is the preliminary results of the assessment. Can I have the next slide? So by way of a little background, here in Nigeria, our population is, very large, over 200 million people, with some of our, health indicators reflecting very high maternal mortality, as well as low usage of family planning, especially modern methods, in terms of coverage for primary health care, just over 30,000 primary health facilities, which is inadequate, low literacy rates, as well as inadequate number of healthcare providers. Next slide, please. So in terms of, the role of healthcare providers, individuals cannot optimally adopt self-care practices and behaviors in order to take greater responsibilities of their health without the support of, health providers. As such, it is very important, to develop trust between healthcare providers and community members, as well as individuals, which is very important. Other roles include, being point of access and support for self-care, as well as playing the role of frontline workers in empowering people for responsible self-care at community level. Also, being health promoters, as well as creating awareness in the community, as well as supporting health literacy. Next slide, please. So going on to, the earlier, results presented, it was understood that, in terms of a few themes that were picked up from the assessment, knowledge about self-care and its understanding among healthcare providers was very, very, very high. They even shared some of the self-care they practice, especially those during the COVID-19 pandemic and the response that followed. But importantly, if you remember, we said, the number of healthcare providers is inadequate in the country. So in terms of that, healthcare providers, as part of what they shared, is the fact that if communities and individuals embrace self-care, it will, lead to reduction of their own workload, which is a very important implication, because that will enable them to, focus more on other specialized care. Looking at benefits of self-care, they reported things like, self-confidence among individuals, giving them, more autonomy, as well as education and information, and increase in terms of uptake of services, including family planning. Now, this is very important for, women and girls in many communities in Nigeria, because of, the, common cultural norms and gender dynamics, which, disempower a lot of women and girls, especially in decision-making, including that of their health. So this will, give them more agency, voice and choice. The healthcare providers also, shared a few concerns, including stigma, accessibility, and, side effect. Talking about, backlash from men and partners or community in itself, as well as stock out, persistent stock out of commodities. Of course, low literacy also was a concern regarding understanding of side effects of some of the services in terms of self-care. Next slide, please. Other findings from the assessments include things around implementation. Importantly, there was suggestions in terms of the role of government, role of individuals, role of communities, as well as the structures that are available in communities as well as facilities. So I'll take government firstly, which has in the past few years developed and implemented policies as well as guidelines like the TSTS policy, the DMPA Accelerated Introduction and Scale-Up Plan, as well as the current National Self-Care Guideline that is ongoing. Health providers saw this as, very good platforms from which information and services, could have an enabling environment. Again, the government also supports community health influencers and promoters program, where agents who live within communities also support in awareness creation, provision of information, as well as some services, as well as what community health extension workers, as well as village health workers, do. So healthcare providers saw this as, as structures from which increased access to information and services could be leveraged on. Also within communities, they also identified, community structures like cultural and religious leaders who can, be used to increase awareness within the communities. Importantly, there was also mention of other structures like the World Development committees, as well as community-based organizations who are there within communities that will serve as play an important role in terms of accountability. Next slide, please. In terms of some of the recommendations they gave, they include, suggestions to see the full implementation of the National Self-Care Guideline, increase availability of commodities and supplies to check incessant stock outs, improved in enabling environment, including funding, as well as increased use of technology. So in terms of key takeaways from, the assessment, we came up with, suggestions as to come up with an SGBV strategy to, generate demand. Secondly, develop appropriate messages for awareness creation, understanding and leveraging on channels of information to reach out to communities, as well as identification of key stakeholders to work with in terms of implementation of the self-care guideline, as well as strengthening monitoring, coordination, and accountability for the implementation of the self-care guideline. Next slide, please. So at this point, I would like to hand over to Ronnie Lovitch. Ronnie has been promoting self-care practices in women's health since the early 90s as co-author of Where Women Have No Doctor. Developed with women groups around the world, this work has been translated into over 30 languages by community organizations. Since its publication, Ronnie has been working in support of programs and services that equip women and young people with information, life skills, and supportive environment to adopt healthy practices. She has played technical leadership roles for many years with Save the Children, Elizabeth Glazer Pediatric AIDS Foundation, the Education Development Center, and has been consulting most recently with UN organizations like UNAIDS, UNESCO, UNFPA, and UNICEF. The work she's sharing in this forum was conducted with UNAIDS in Eswatini. Ronnie, you're welcome, and I hand over to you. Thank you.
Thanks, Yusuf. Can I have the next slide? And the next slide. So self-care should be playing a more important role than it may be in HIV prevention and risk reduction in particular. But doing this requires us to think a little differently in terms of how we help people to recognize risks that may be in their lives, think critically about them, and then make positive changes to help them reduce that risk. Understanding how risk is perceived to the population groups we're trying to reach is a crucial but often overlooked step in the process of planning. Next slide. As Yusuf said, this work was commissioned by UNAIDS, and it was co-led with NERCHA and the National AIDS Program. And the aim was to develop operational guidelines and tools which would support risk reduction activities across a variety of platforms in Eswatini as a complement to currently used HIV core packages. Eswatini is among the highest prevalent contexts in the world, and despite this, risk perception across population groups remains low. I'm going to share some learning from the process that we use to better understand risks from the different points of view of population groups, and also some learning from the piloting of some risk self-assessment tools. Next slide. So we worked with a wide range of groups, all of the priority populations, so adolescent girls and young women, adult men, all of the key population groups, including those in correction facilities, and other population groups, including young people and adults living with HIV, women over 25, and adolescent boys and young men. Next slide. So our starting point for this work was understanding that in order for somebody to be motivated to adopt a protective practice, they have to have sufficient health literacy, so enough information to recognize the risk, as well as their protective options. They need to see themselves as being at risk and that the risks are actually relevant to their personal situation. They have to believe that the consequence of that risk is worth preventing and that the consequence actually outweighs the reason they're taking the risk in the first place. And agency, knowledge, life skills, and confidence to believe that they can protect themselves and make change. Next slide. So underpinning this work was Can I have the next slide? Oh dear.
Sorry, Ronnie, you were frozen for a little bit, but you are back.
Oh, good. Can I have the next slide? Okay, we used 4 domains of risk to explore risk. We had one-day consultative processes where we worked with specific groups, and we explored risk from the point of view of risky sex, risky relationships, risky lifestyles, so some of the lifestyles and behaviors that were actually driving unsafe sex, and then situational risk, understanding that sometimes there are risks and vulnerabilities that people have less control over in their lives. Next slide. We did this as a 2-part process. We had first the population groups exploring risk, both within these one-day consultations, but then in their communities with peers, where they conducted interviews with peers to validate what they determined during those one-day processes. We put this together with technically defined risk, where we brought together experts and frontline workers who work with different population groups to share their perspective on risk. Next slide. So we determined that there were perception gaps within each of the population groups. There were a number of points that people were missing in terms of risk behaviors and risk practices and risky situations. So one of the most consistent across all population groups was partial condom use and a lack of understanding that it wasn't as protective if you put it on later during sex. At the same time, if we were to ask, did you use condom at the last time you had sex and with every partner, we'd still get the answer yes. So not only would we be missing information from a recipient point of view, but we'd also be missing it from a provider point of view. There were a number of risk practices across all groups consulted, and a lot of nuance in some of the lifestyle issues, the transactional sex issues, had a range of motivations and really needs to be better attended in terms of different reasons people are involved in transactional sex, and also with concurrency and multiple partners. A lot of learning in terms of how people find partners, especially for casual sex, which also brings a lot of risk. Next slide. So in addition to whether or not people are perceiving themselves at risk, there's also how bad is that risk? And there were gaps in terms of what we might perceive as HIV being a terrible thing to happen, whereas other people, well, pretty much across the groups, they were saying unintended pregnancy was seen as a much worse consequence and something they feared more. So it really presents a dilemma because we don't want to introduce messaging saying HIV is a death sentence, of course, but we want to make sure that there's enough balance in our messaging so that people do see it as a serious enough consequence and something that needs to be taken seriously. Okay, next slide. So the tools that were developed as a result of these formative processes were to be used in a range of platforms and programs, including health service waiting areas, community support groups, different settings in school and out of school for life skills education, mentorship work, workplace prevention, and parenting groups, as well as in correctional facilities. Okay, next slide. The 12 sets of assessment tools were developed for both provider risk assessment as well as risk self-assessment, which could be administered by people themselves. The tools had two parts, the first being a personal inventory that included risk questions, and then for each area of risk, they identified information to consider for the identified risks and then options for reducing that risk. And then a second part, which promoted personal protection planning, where people identified the specific risks they wanted to reduce, actions, doable actions that they could take, and then the supports and services that they would need in order to do that. Next slide. Most of the tools were piloted, but not all, in a range of community, workplace, and clinic settings. Next slide. Based on the piloting, people did see some of the information that was included as new and useful for them, especially around PEP and PrEP, and also that PrEP was available for more than adolescent girls and young women, which was a misconception. Lots related to sexual practices and hygiene practices that people hadn't recognized as risky before. And then in terms of protective actions, what people said they wanted to commit to included range from abstinence, PrEP seeking, and lots of focus on improving communication with partners and partner reduction, and a lot of focus on investing more in relationships and avoiding situations of heavy drinking. Next slide. So people like the idea of personal protection planning as something that they could do for themselves. The tools themselves were a little bit heavy and complex for some of the population groups and required heavier facilitation for those with literacy challenges. That's not a surprise. Sex workers in particular needed some support, but they did like the idea of developing a plan of feasible actions that they could take. Young people needed a lot of follow-up once risks were identified. Also, not surprisingly, there was a lot of sexual abuse that was uncovered through this process, and so support that was necessary. One of the most interesting findings was that in the clinic settings, women wanted to take these tools home to use as conversation starters with their partners as a way to review their relationship and some of the risks in their relationship. So follow up on that would be interesting to see how that worked out. Next slide. Final takeaway points, there's more we could and should be doing to build health literacy and agency for risk reduction for HIV, but for other problems as well. But to do that, people first have to understand risks, and we as programmers need to understand risks from a range of points of view and what those risks mean to people. And overall, there is more work that really should be done in this area. Okay, thank you. Sylvia, back to you.
It's Erick, actually. So Erick.
Thank you very much, Sylvia. Welcome everyone to this second panel on reproductive empowerment and self-care. We've heard a lot about self-care, but in this session, we basically want to hear about what is reproductive empowerment and how does it relate to self-care. For this panel, I'm joined by two of my colleagues, both from Uganda. One is Hajra Mukasa, who is a public health specialist with a bias towards sanitation and hygiene promotion within the circular economy for the last 15 years. Hajra is presently the WASH program manager in Uganda, and she provides technical leadership to WASH programs for AMREF Health Uganda. After Hajra has presented, we would have Priscilla Nabatanzi from Reproductive Health Uganda. And Priscilla will be able to share with us the gender norms around SRH and looking at SRH and how self-care is perceived from the perspectives of young people. Priscilla is a national sexual and reproductive health trainer and has interest in sexual and reproductive health and livelihoods for young people. And she has passion in menstrual health management for girls and boys for support, including psychosocial support. So thank you very much. Next slide. Yeah, so, and I'm, yes, good. Yeah, so let's proceed from here. So we've had a lot about self-care, but when we talk about reproductive empowerment, and the previous panel talked about self-care in details, and what we're able to glean, and basically from the WHO definition is about basically ability of those individuals. But when you think about young people, when you think about women, what does self-care mean? And when you think of self-care at the same time, you need to, when we started, I saw people in the word cloud that we started with. I saw that the biggest word that came out was empowerment. So the question is, self-care and empowerment, what leads to which one? Does self-care leads to empowerment, or does empowerment leads to self-care? And what are the key indicators for empowerment? And how does it change across the various contexts and also across various population groups? Move to the next slide, please. So to start with, we will look at what reproductive empowerment is, and we'll give you an opportunity of contributing to this discussion also. But when we, at ICRW, we've looked at reproductive empowerment and tried to define it as a transformative process that it has a number of very specific keywords, that it's a transformative process and it's also an outcome where individuals are able to expand their choice. And they're able to make informed decisions about their reproductive lives and their ability to meaningfully participate in public and also in private, so that they're able to act on their preferences and choices. So this is how we've looked at it. So, but the most important thing when you think of reproductive empowerment is that this process must take place in an environment that is free from violence, from retribution, and from fear. This is how we've defined reproductive empowerment. And move to the next slide, which is basically an opportunity for us to use a Slido chart. In your experience, what would be the component of reproductive empowerment based on the definition that I've just given you? So in the chat box, Natalia has posted a link to this Slido. Please feel free to type. Yes, I see Martha has typed about aligning risk perceptions with actual risk, but if you could use the Slido so that we can see all the what everybody else is saying. I hope everybody is able to see the link to the Slido poll. I'd give you a minute to be able to type your responses. So I see decision making, thank you. Choice, autonomy, control over your own body and decision making, information, aligning perceptions with actual risks. Yeah, there's decision. There's a lot, how to align perception with risk, the choice. So I think I'm seeing choice, full knowledge, autonomy, freedom, method choice, voluntary selection. Yes, thank you very much for this. Please continue typing all your inputs into this. We'll be able to consider this, but we can proceed to the next slide, which you basically mentioned some of the components of reproductive empowerment. And I read choice like 4 or 5 times. I read voice.
1 more minute, Erick.
Sorry?
1 more minute.
Yes. So so there was also the issue of power, agency. There's also the issue of resources. So this is basically what we've talked about here. Move to the next slide, please. So for us to be able to really contextualize reproductive empowerment, we took a socio-ecological approach to reproductive empowerment, and we presented this in a chart. So, and the most important thing when you look at agency, it basically happens at various levels. So there is agency at a distance relational level. There's also agency at the individual level. There's also agency at the immediate level, and then that distance relation level. So the most important thing when we talk about reproductive empowerment, it happens at various levels. When you talk up, and it starts from individual level, then the immediate, and then the distance level. Being able to really look at what is what this level shape, how this level shape this relationship that people have. Next slide, please. So what are the implications of reproductive empowerment and self-care? So like I've mentioned, reproductive empowerment is an inherently relational concept. And therefore we need to understand these relationships very, very important and very critically. And in order to encourage empowerment and self-care, encouraging empowerment and self-care is an essential ingredient in supporting women to be at the center of their own care. So very important to be able to bring those two aspects together for self-care to happen. At this point, I would like to invite my colleague Hajra from AMREF to be able to share with us examples on how self-care has been, to give us example of how self-care has been used in Uganda from the AMREF's perspective. Welcome, Hajra.
Thank you. Can I have the next slide, please? Yeah, my name is Kafat Hajra Mukasa. I am the Program Manager for Water, Sanitation and Hygiene at AMREF Health Africa in Uganda. I'd like to pose a question. Did you know that providing information and awareness creation about self-care and reproductive health alone is not good enough to enable mothers and youth make healthy self-care and reproductive health decisions? I wanted to meet a 35-year-old Janet Achom, who made a decision to offer self-care to herself, and this time it was to deliver her baby herself from home. Her decision was informed by the poor water, sanitation, and hygiene conditions at the healthcare facilities that were next to her. The good news is she got her baby. The bad news is that she developed profuse bleeding after just 2 days. In addition to that, her baby was behind schedule, so the girl could not walk at 1.5 years. So as AMREF, we saw the need to enable communities make better decisions by providing enabling environment, thus integrating water, sanitation, and hygiene into maternal reproductive health services. Next. Next slide, please. So we took a walk around the healthcare facilities that are providing reproductive health services. And interestingly, of all the health facilities that were offering reproductive health services, 33.3% of them actually had what we would call public latrines, because these latrines were being shared by communities. But while these latrines were being shared, they were all dirty. None of them had hand washing facilities. And so they were repugnant and could not provide an enabling environment that would encourage a mother to come for reproductive health services, despite being aware of the need to deliver from a healthcare facility. Next. A further walk in the healthcare facilities proved what Jenna Chom had told us. The post-delivery room, you can see cow dung on the floor and the bed is not dressed, but a mother is expected to use that bed after delivery. And the mother is supposed to go and bathe in that bathroom that is being shared by a pig. So what motivation would I have to really go and deliver from a healthcare facility, even if I had the information to do so? Next. Yeah, the picture in the community was not any different. There was obvious open defecation, and yet there was open water sources. That means that obviously When it rained, all the feces ended up in these open water sources. And yet we are telling mothers to take good care of the baby's cords after delivery. So the self-care that a mother is supposed to give to her baby was being hampered by lack of access to clean water and sanitation services within these communities. Next slide, please. And when we talk to healthcare service providers, their concern is that they did not have the equipment and facilities to offer good services. But when we talk to other healthcare seekers, they had a different opinion. According to them, the health workers were not friendly. So we found a mismatch in these invoices. So we realized we needed to have change agents to help raise voices on self-care and reproductive health services, but we also needed to have a platform where voices are heard from both sides. Next. And so we decided to have platforms for community dialogues through integrated outreaches, where health workers were given an opportunity to listen to the communities and the communities to listen to the healthcare workers. We also built capacity of these healthcare workers, not only to provide the technical services, but also to offer customer care to health workers, to the healthcare seekers. But then also we knew that we were promoting self-care in terms of cord care, post-delivery care, offered by mothers themselves. So we built capacity of community health workers to help enhance that service by reminding the mothers of the key things that they had to do. But also we had to improve the water, sanitation, and hygiene conditions in healthcare facilities. We used that opportunity to create a joint point where communities would meet to have discussions, and what other than a water source where everyone agrees to. And so the water points that were near the healthcare facilities became a meeting point where communities would dialogue with healthcare facility service providers. Next. Our efforts paid off. We saw increase in ANC4, which is a measure of care, from 11% to 78%. Delivery under skilled healthcare rose from 17 to 75%, and we saw reduction in diarrhea incidences in communities. But then we were able to see women who do not even wear shoes when they're coming for meetings, willing to save money to be able to get better healthcare services, including referrals to healthcare facilities. And we're able to build the knowledge and skills of youth to provide services to their communities to promote their own sanitation and hygiene services in homes. Next. And so basic facilities like a placenta pit gave mothers assurance that when they came to deliver from healthcare facilities, their placenta would not be carried away by dogs as a result of being thrown in the open. And that made them make better health decisions in reproductive health. Next. So like I said, we empowered the youth with knowledge and skills to offer services to their own communities, improving sanitation and hygiene services, therefore moving out from open defecation, you see on the left, to latrine facilities on the right. Next. And so in conclusion, as AMREF, we believe it's true we can advocate for policy, we can increase awareness and continue raising voices about self-care and better reproductive health services. But giving information alone without creating an enabling environment in terms of better healthcare service facilities, that the healthcare facilities would not be enough to enable mothers and youth make healthy decisions about their reproductive lives. So we need to take a holistic approach to not only look at the software, but also look at the hardware. And on that note, I would like to invite my colleague from Reproductive Health Uganda to come and join, and her name is Priscilla. Welcome, Priscilla.
Thank you very much, Hajra, Comfort, and Eric. Please proceed to the next slide. Thank you very much. I am representing my colleague, Motovu, who is supposed to be in this session, but nevertheless, look at me as him. We are looking at gender transformation in SRHR, but also in relation to self-care. And this is just a photo of a man trying to show positive masculinity that we also want to promote in issues of reproductive health and reproductive justice, and also self-care. Please proceed to the next slide. Thank you. I also would like to pose a question before we proceed, and people could use the chat or the Slido. What could they share some of the responses or their worldviews of what they see in that particular slide? In just a second, anyone could share anything. It could be in the chat. Wow. Okay, I will just proceed. So when you look at this particular slide, someone is saying brilliant colors, beauty. I see beauty, colors. Anything else? Beauty, a male bird, power. So thank you very much. So that is a representation of diversity. Someone could interpret it as diversity. Someone adds on a peacock and welcome etc. So we see that it could be a representation of diversity, people's worldviews, people's perspectives, which are also shaped by the agenda that is constructed by this community. Please continue. And wow. Okay, this brings us to the slide that tries to unpack what gender is. And we look at gender as the socially constructed attributes to male and female, or men and women. And we also know that it varies from culture to culture and with economy and social and the political context. And it also takes us back to what we have just been looking at. The way people see things, perceive them, also shapes what their gender is. We also see that it varies with time. And then it also looks at the roles, and we need to note that gender is also very, very different from sex. Thank you. Please proceed to the next slide. So the next slide brings us to what we are looking at as transformation, which is also brings us to the most important factor, that is self-care in this sense. We realized in the previous slide that as we look at gender and how it shapes people's perspective, worldviews, and their decision-making and empowerment and all that, we see that self-care is also affected by gender, since it is a socially constructed thing based on what your sex is. So in this particular slide, we want to see how do we change the story to moving from equality, equity, and to liberation, because most of the times we see these particular individuals struggling to see, okay, government or civil society or any other person has provided equitable resources or furniture or name it all to ensure that all these people are able to view what is happening in the field. Me and you are able to see that some of these people are not able to see this. And when you go to equity, they're trying to do that as per everyone's needs in the society. But still, it is a bit challenging. And what everyone is aspiring for, especially in the civil society world, and particularly us as reproductive health, is how do we remove all these barriers? For example, how do we get off these ladders, the steps, the fence, and have liberation? Let everyone have the step. Let everyone have equal everything, to see that there is no barrier, there is no culture or negative attitude or norms that are actually hindering people's access to reproductive health, justice, and other services, and even self-care itself, because it is the people's values, norms that hinder them to do some of the self-care things they would have done to themselves. And then they end up missing out on preventing disease and so many things. Please proceed to the next slide. So in changing the story, Reproductive Health Uganda has a number of programs that run across the country. And in this particular photo, these are women champions. They're a bit older, but they're also some young girls. And these are female champions that have been grouped into 10 groups or helped to form groups, which groups have been oriented, capacity built to provide SRHR information to other people within their communities. And yeah, it was just after a training where they felt empowered to actually share information with their own family members, but even outside their own family. And then there is also the bit of capacity building of healthy workers, where we have to ensure, or we have ensured, that gender responsive services are provided to all communities, young people, male and female, and other marginalized groups of people. Please proceed to the next slide. And with that, we've also continued through the female champions to sensitize communities, like I highlighted earlier. We've also engaged decision makers in advocacy, and here the lady you see in an orange and white dress was trying to meet up with the community leaders on one of the advocacy issues that we had, which was in one of the districts called Hoima, which was fighting against the Kavera or polythene bag alcohol. Yeah, thank you very much. Which was a Kavera or polythene bag alcohol that they thought it is causing a lot of SRHR challenges. So they're trying to help the community leaders understand this and appreciate the beauty of doing away with that particular type of alcohol, to see that women are able to access services and be able to take care of themselves. Then we also see the males within that. Then we have also conducted dialogues, and these dialogues bring on different peoples, like you see the intergenerational, it brings the young, the old, all kinds of groups of people to see that they dialogue on issues of reproductive health. Then we've also formed a civil society advocacy coalition to advocate for gender responsive programming. And with this, we have, I think last month or beginning of this month, this coalition was actually launched. And a number of programs are being speared to see that we have gender responsive programming integrated into all the other things that we do. Then we've also been able to conduct gender analysis in local government programs, in particular in Hoima, and even within our own institution, to see how best can we improve gender programs within the different institutions as we program or we want to see a liberated society. And lastly, we've also advocated for integration of key indicators of gender in relation to the M&E tools, so that we are able to monitor how far facilities, the different institutions have gone to work or to have gender as a key issue in their programs and in their institution. The last slide, which is just, please proceed. Okay, so that is all we've done as Reproductive Health Uganda. And thank you very much. I would like to hand you over to Erick Yegon.
Thank you very much, Priscilla. So this is the end of our panel, and I'll take it back to Sylvia for.
Was I talking to myself? Hello.
Priscilla?
Priscilla, we can hear you.
Yes, we can hear you. So don't you worry, we can hear you. So Erick, I'll take over from here. So one thing we can take away from this session is the approaches that can be used to determine and improve self-care systems. And most importantly, we really look at the human-centeredness of each one of them. So there's some questions that have been raised, and these questions are particularly to the first speakers. And this is for the first panel. And what we want to encourage you, because of time, is to respond to these specific questions that have been asked. The first one is from Sinkira Ephraim from Ghana, who asks, what is the benefit of self-care? Does it really matter? And the next one is for Dr. Adewole specifically, and it's from Annie Bayo from Congo. Her question is, who has the priority to self-care? Is it men or women? And in a country where people are untrained, what are the measures taken by Wide Ribbon Alliance to teach them? Maria Carrasco does ask, can you speak to how the concept of self-care is helping to put the light back on the importance of HIV prevention? So for these questions, I'd like to encourage those presenters to please go ahead and start and please respond directly. We will skip the Q&A, which we had scheduled before, and move straight to small group discussions. So I'd like to encourage each one of you. We're going to break into sessions, into group discussions, and you're going to be broken into 2 groups. And these breakaway sessions are time for you to interact directly with the panelists. So over to the technical team to please go ahead and do the breakout rooms. So please come back right here for a really, really interesting session. So I encourage you, please don't leave, participate, and then get back here so that we can continue with our presentations.
All right, thank you, Sylvia. I'm gonna go ahead and break everyone out into breakout rooms. If you require interpretation assistance, please press return to main room, and main room will have interpretation available. There'll be 4 groups, 1 in the main room and 3 breakouts.
Hello, Natalia.
All right, we are in the breakout room. I believe that Joan is facilitating this conversation. You can go ahead and speak up and we can begin talking together. All right, it appears that she might not be in this room, so one moment.
Natalia, are you able to find Joan? If not, I can just step in and ask a question for people.
She should be in this main room. She should be joining.
Okay.
Hi, Joan. You can go ahead and begin.
Hi, yes, please. Hello?
Hello.
Yes, please.
Go ahead, Joan, we can hear you. Joan, can you hear us? You can go ahead and start facilitating.
Sorry, I'm having a bit of technical issues on my end. Could someone start standing a bit for me? Sorry.
Sure. Yes, we only have a few minutes, so let's go ahead and get started. But the first question that we wanted to pose to people is, what does reproductive empowerment mean for access to self-care at the individual and community level? So feel free to unmute yourself and just share some of your thoughts about what reproductive empowerment means for self-care at those levels.
I think reproductive empowerment means not feeling pressured to make decisions based on something that you think is outside your control, such as family pressure or cultural pressure, and to understand that this is your right and you can make your own decisions.
Thank you so much. Yeah, making your own decisions and not being worried so much about what other people are thinking or saying. Any other thoughts that people want to share?
I'd add to what has just been said and say it's really about the resources and just having access to this kind of resources and a myriad of resources, so you're able to utilize them, be able to make effective decisions when it comes to your own body. And these resources would include knowledge as well, you know, and also mental health. And so this could promote, you know, self-efficacy. So I'd say resources is one primary thing that you know, would contribute to what reproductive empowerment is.
Thanks, Sylvia. So back to Erick's framework that included resources. Priscilla, were you going to say something? Sorry.
Yeah, because it relates to what Sylvia has just said, because it brings me to the definition of reproductive health, of when am I supposed to give birth to children if I want to, when should I get married. It gives me that autonomy to make decisions for myself and to be able to send back messages to whoever is creating any form of negative energies around me, but also most importantly, the issue of reproductive justice is addressed in that relation. Thank you.
Thank you so much. Do others want to add any thoughts about what reproductive empowerment means for access to self-care? Okay, so maybe another question then here is, what should we stop doing in order to enable young people to exercise choice, voice, power, and agency around self-care? What should we stop doing?
I think religion and culture should not be fronted when someone brings out issues of accessing reproductive health services, because they are so much of a hindering factor. For example, here in Uganda, where you see someone wants to access information, just information or knowledge on maybe how to use a condom, and someone is already going to say, oh, you're not old enough to learn about this. So I think those two issues shouldn't be fronted. They are very important, but they shouldn't be fronted.
Yes, thank you so much. Other thoughts about what we should stop doing?
I think even stigmatizing young people should be stopped.
Mm-hmm.
Yes, that should be stopped.
Yeah, that stigma to either access that information, as you were saying, Priscilla, earlier, or access the actual products for self-care. Any other thoughts?
I seem to have so many answers. The other thing I think that should be stopped, because I do a lot of young people programming or youth related programming, and I appreciate everyone here maybe does. But yes, I think the other thing that should be stopped is planning and budgeting for young people. Let them be part and parcel of this planning and implementation and budgeting and everything, because they better understand what they are going through. And I also appreciate that the adults do, because that's where they passed, but we should be very keen on having them on board all the time, rather than having them as in form of tokenism or manipulation, or wanting to show that, okay, they are here, but they are not active at all. So there should be, that should also be stopped. We shouldn't think for them, plan for them, let them be equal partners.
I think I'm talking from India, and from some very, very sad but really true situations where families make decisions for girls and young boys on who their life partner is, and marry them off way before they themselves have even thought about the choice. And I struggle about self-care in such situations, because I think there's so much more that society needs to do, and the agency of the self may be very, very minimal in this area. So I'd like the speakers to give us some sense of how do you even think of self-care in situations like that.
Yeah, thank you so much. That's a great point. And I think it plays to what Annie put in the chat here. There's just that cultural barrier, and what kind of real power and access do youth have? Any of the speakers from the first panels, do you want to respond to that question?
All right, just noting that we are closing up breakout rooms now.
Thanks, Natalia. If anyone wants to share a final closing thought, you're welcome.
I think denying services to young person should also be like stopped. Not giving them proper information to take the informed decision. I think.
Thank you so much. Priscilla or Adewole, do you have any other thoughts? I guess other people are joining us now, so we'll wrap up.
Just noting that everyone is back in the main room now.
Welcome back, everybody. I do hope that you did have some insightful sessions. We didn't have enough time, unfortunately, but well, what do we say? Our next session actually hosts two exciting panels, and one is specifically on behavioral insights into self-management versus provider care, and the other one is on behavioral journeys in self-care. In the first two panels, we had a chance to learn more about how communities interpret and apply self-care and how this translates to reproductive empowerment. Now, we will learn more about how these distinct populations take up self-care and gather insights on the factors that influence behavioral trends in self-care decision-making. This is what the final exciting panel is all about. And this is really about thinking about how provider care versus self-management is about. And we journey to Bangladesh, and where we have great learnings from garment workers in Bangladesh. And we will also get some insights from a very interesting program called Desk on This. So let's, without much further ado, allow me to introduce the panel leads. And the panel leads are Rahin Kandekar and Kankar and Heather Hancock. For the first panel, Rahin Kankar, let me just tell you a little bit about her. She has over 10 years experience designing, implementing and testing behavioral science interventions on higher education and international developments. She's currently a vice president in the global health domain of Ideas 42 and oversees a portfolio of projects that are aimed at improving the quality and uptake of family planning, reproductive health services, and maternal and child services. The second panel is led by Heather Hancock, and Heather is a senior programs officer at Johns Hopkins Center for Communications Program. And Heather is a social and behavior change specialist with expertise in the field of reproductive health and family planning. Her areas of expertise include integration of social and behavior change and service delivery, provider behavior change, capacity strengthening, and online community management. Also, when it comes to materials development and curriculum development. So allow me to welcome Rahin. So Rahin, welcome the first panel.
Hello, thank you, Sylvia. Can everybody hear me? Thumbs up. Yes. Next slide, please. Great. Thank you. Welcome, everyone. Thank you, Sylvia, again for the introduction. My name is Rahin, and I am very excited to share with you all some of the work that we've been doing in Bangladesh with our partners to enhance self-care and empowerment in family planning. Next slide, please. The objective of this panel is hopefully to illustrate how behavioral design can enhance self-care in a way that both empowers women to take control of their lives, but also links women back to providers at the right times if necessary. Now, when I say behavioral design, what do I mean? Behavioral design is an approach that mixes economics, psychology, human-centered design, and other disciplines to come up with innovative solutions to challenging problems. An interesting aspect of behavioral design is that it forces us to pay attention to small details when designing programs, because oftentimes these small details have a big impact on human behavior. And so hopefully throughout this presentation, I can illustrate the importance of these small details. And the case study that we'll go into today is a project that we did in Bangladesh. And the consortium of partners that worked on this project are Pathfinder International, Camber Collective, ICRW, and Ideas 42. And this was a project funded by the Gates Foundation. Next slide, please. So let's start with a quick snapshot of Bangladesh. Bangladesh is really interesting because on the one hand, it has extremely high uptake of family planning. You know, the modern contraceptive prevalence rate in the country is around 63%, and most women are hitting their ideal family size of around 2 children. What's interesting though is Bangladesh also has high rates of unintended pregnancies and abortion. So in 2014, 48% of pregnancies in Bangladesh were unintended, and over half of those pregnancies resulted in termination of the pregnancy. So the problem again is, you know, there's high uptake of family planning, but also high termination of pregnancies is a method that women are using to reach their ideal family size. So what's going on here with this problem? To understand this, our group took a closer look at garment workers because this was our key population of interest. So next slide, please. So if we take a closer look at garment workers have a high opportunity cost to unintended pregnancies. There's a lot of consequences, especially because many garment workers, if they become pregnant, do not get paid maternity leave at these factories. And so many garment workers do not want to become pregnant, yet at the same time, they rarely have time to visit health clinics where they can get proper counseling on all the different family planning methods available. So in this context, garment workers often use oral contraceptive pills or OCPs, and so one thing we found was that a lot of unintended pregnancies among garment workers result from discontinuation of OCPs. And these OCPs, it's a large preference for garment workers and many women in Bangladesh because they're easily available, and many of these for garment workers can be obtained over the counter at pharmacies. And so in this context, you know, it does make sense that you can have high uptake of family planning, especially because the most common method is OCP, and then high unintended pregnancies that result from discontinuation of OCPs. So next slide, please. The self-care challenge here that we ended up addressing is how can we help garment workers adhere to their first method of choice, but also empower them to switch to a more suitable option if they find OCPs unsatisfactory. And so to address this challenge and to come up with a solution, we underwent a behavioral design approach, and this involved doing in-depth qualitative interviews with over 85 garment workers, health providers, husbands of garment workers. And then we also did co-designing of solutions and obtained feedback from garment workers on early drafts of our solutions. And based on all of these insights together, we were able to kind of develop our solution. So next slide. What did we implement? Our solution, we partnered with Pathfinder and Murray Stopes Bangladesh MSB to implement our solution. We implemented it across Murray Stopes Bangladesh health clinics and MSB pharmacies. And I do want to take a quick second to draw this distinction because at health clinics, garment workers will have the full spectrum of FP counseling, but there's longer wait times and it's the less preferred option of garment workers. If you look at MSB affiliated pharmacies, there's only OCPs that are offered. There's also, I see someone mentioned there's menstrual regulation kits that are also offered at pharmacies. But these pharmacies also have shorter wait times, and it's typically where garment workers go to first. So it's their first choice. And given that pharmacies are the first choice for garment workers, a big and the largest component of our solution that we implemented actually took place in pharmacies. Next slide, please. So what did we implement? Our solution actually had 3 components. The first—
One more minute, Rahin.
The first component is an enhanced pill packaging, or OCP packs. And so when garment workers obtain pills from either the pharmacy or from an MSB health clinic, they are given alongside their pill a large decorated envelope. And this envelope has reminder stickers, visual instructions for taking the pill, and a number to call the hotline or enroll in IVR services, interactive voice response services. The second portion of our solution was a planning prompt. So if garment workers chose to go to health clinics instead of the pharmacy, then garment workers and health providers together could sit down and make a plan on how to adhere to oral contraceptive pills together. And then the third component of our solution was just for health providers at MSB clinics. And it was essentially a refresher training that was a little bit more client-centered and scenario-based. Now, this solution, given that garment workers are going to pharmacies first, and I want to hone a little bit more in on our enhanced pill pack, because that's the solution that was, it's the largest part of our solution, and it was implemented in pharmacies. So next slide, please. So when garment workers go to either, go to the pharmacy and buy a pill pack, alongside the pill pack, they're given a large decorated envelope. And on the envelope, it has written, it says an exclusive pill offer program for you. And the reason we did this from a design perspective is we found that if we have this beautiful envelope accompanying their pill purchase, garment workers, it grabs their attention, and they're significantly more likely to actually open the envelope and go through all the contents of the envelope, which contains our core solution. And so again, something as simple as the design of this envelope to make garment workers feel special can go a long way in having them just engage with the solution as you intend them to. Next slide, please. And so the second part, as a garment worker opens the envelope inside, they will come across some reminder stickers to remind them to take the pill. So if you look on the left of the screen, the 2 boxes outlined in orange are examples of stickers that a garment worker might come across. The sticker on the very left is it's deliberately discreet. In Bangla, it just says remember, whereas the sticker on the right is very explicit, and it shows a woman actually taking the pill. And this was done based on feedback that we got directly from garment workers, where some preferred this to be discreet, some preferred it to be explicit. And so this would accommodate for the different types of garment worker preferences out there. But the idea here is that a garment worker can put the sticker beside their bed or on the mirror in the bathroom, and it would remind them every day to take the pill at the same time. And why did we do this? Well, we found from our interviews that garment workers have a lot of scarcity of time, and their overloaded schedules, have really long work hours, and no reminders to take the pill. And so it's easy for them to forget. And we have this quote here, sometimes there's gaps, as I forget, sometimes I'll take one after 2 days, one after 3 days, sometimes I don't take anything. So a small change in the garment workers context is putting a sticker, some of them put it on their phone, can go a lot in terms of changing behavior. Next slide, please. So another component in the envelope that garment workers would open is the visual instruction sheet. And the reason we did this was that we found oftentimes garment workers have inaccurate mental models on how to take the pill. They hear informally incorrect information from their friends. So you can see the quote on the right, this garment worker thought that the day that you have intercourse, you only need to take the pill that day. And so a visual instruction sheet, because the literacy is some garment workers are not literate, the visual instruction sheet can draw their attention. There's a number for them to call to figure out how to use the pill. It's easy for garment workers to show this to a friend that they trust to figure out how to do it. And it's a lot better than just having a block of text, which we found could be daunting. Another interesting kind of component is when garment workers are purchasing pills from the pharmacy. Pharmacists are typically male, so if a garment worker does have questions around how to use the pill, it's very unlikely that they'll bring it up to a pharmacist. And so in that setting, if a garment worker is in a pharmacy, they're more likely to leave with an inaccurate mental model of how to use the pill. Next slide, please. And so the last component in the envelope is a number to call a hotline. The idea is that garment workers, the day they open the pill pack and start taking the pill, they call this hotline, and providers prompt them if they want to enroll into an IVR service. And if they agree, then from the day they start the pill, there's strategically timed voice recorded messages that are sent to the garment worker's phone that can help them along their journey of taking the pill. And the reason we did this was that we found a lot of garment workers experience side effects from taking the pill, and they have limited options of what to do if they experience side effects. And so, oftentimes they'll either stop taking the pill or they'll change the dosage to manage the side effects. So instead of taking it every day, they might take it once every 2 or 3 days. And we found that, the idea with our IVR program is to reach garment workers even before they experience the side effects, and have these strategically timed messages. So the first few messages might be just simple reminders to take the pill, whereas after a week or after a week and a half, the messages might prompt the garment worker to see, do you have side effects? If you have side effects, press 0 and we'll link you to a provider. And then maybe after a month, we might prompt the garment worker to, the voice message might prompt the garment worker, is the pill suitable for you? Are you interested in exploring other methods? And over time, the messages can kind of guide the garment worker and link them to the provider at right times and expand their choice set of options of what they can do and what other methods they could consider if the pill is not suitable. Next slide, please. So overall, that's kind of zooming in on the first component of our solution. And I do want to flag that we did a small pilot in Murray Stopes, Bangladesh, and found promising results. And since then, Pathfinder International has worked with the government of Bangladesh to scale this solution set. So I'm just going to send a link to everyone here in case you're interested in learning more about this solution being scaled in the country. And I do want to highlight again that small details in program design matters. So, a red envelope or having discrete or non-discrete stickers, these can go a long way in really helping garment workers or women adhere to self-care programs. And so thank you very much. And I will hand it over to Heather for the next presentation. And if you have any questions, please chat them in the chat and I will take some time and respond to them.
Thank you so much, Rahin. We are really excited to be here with you today to talk about some behavioral considerations in self-care and why applying a behavioral lens is so important to the success of self-care initiatives. I'm going to be kicking off this panel by sharing an in-progress framework for incorporating behavioral considerations and approaches into self-care work. And then following my presentation, Melissa Higbee, Project Director for the Delivering Innovation in Self-Care Project, will present behavioral insights from their self-inject research and program design. Next slide, please. So today I'd like to share with you some work that the Breakthrough Action Project alongside the Evidence and Learning Working Group has been doing to advance the thinking around how we can better integrate social and behavior change into self-care efforts. Next slide. I want to get us thinking, started thinking about self-care through a quick poll. So let's take about 30 seconds to type in some responses to the question here. In your experience, what factors have significant influence on self-care behavior? And again, the link to that poll is in the chat. Great, so I'm seeing access to products has a significant influence, family roles, cost of a product, knowing how to use a product or practice a certain behavior, health literacy, how easy it is to use a product, again, some more knowledge, confidence in being able to do it. Excellent. Again, I see health literacy and confidence, and also a place to ask questions or get help. Let's go ahead and move on. And I'll just highlight that last one about friends using it. And that's a really important one as well. And thank you so much for all these great responses. For me, they really do highlight the fact that effective self-care relies heavily on the behavior of individuals and couples, as we mentioned, some of those family members and friends. However, what Breakthrough Action found through some of our programmatic reviews and desk research was that although there is a broad agreement on the importance of people-centered approaches within self-care, we noticed that behavior change, people and their behaviors are often missing from self-care guidelines or programmatic approaches. A lot of the work that's been done in self-care, which is very important, has focused on the safety and practicality of self-care, but not quite as much as focused on the normative, attitudinal, and health literacy behavioral drivers that people were mentioning just in those responses. So in 2020, a working group consultation revealed the need for some sort of conceptual framework that could organize efforts around integrating behavioral considerations and approaches into self-care. And so Breakthrough Action and the Evidence and Learning Working Group have been engaging a number of self-care and social and behavior change professionals, including government representatives, implementing partners, donors, and researchers across about 12 countries to co-design a framework that would meet that need. And this framework, which is still in the development process, it applies an explicit behavioral lens to sexual and reproductive health related self-care. And it also articulates how a behavioral focus can be used to create that supportive system for self-care behavior. And this framework has been informed by a desk review and also insights from those professionals that I mentioned in that co-design process. Next slide. This framework is designed to be used by 3 core audiences, and that is self-care implementers, government representatives or policymakers, and also donors. Next slide, please. So I just want to highlight a few key components of this framework. And again, please note that this framework is not finalized. We're still in the process of engaging and testing this model as we move forward. So next slide, please. The first key component that I want to mention here is the central importance of a supportive network for self-care. And this may seem a little bit counterintuitive, as we tend to think of self-care as a more individual effort or something that's done in isolation. But what we've seen is that although the process and outcomes of self-care are self-centric, that qualified, empathetic, and holistic social support is really essential for uptake and maintenance of self-care behaviors. And as you could see in that graphic that I shared a minute ago, the individual you can see in the center of the circle really does need that supportive system to encourage and support behavior, and sometimes perhaps due to the regular interaction with the formal health system. Throughout our co-design process, we have found that there are some key actors, and this is not by any means comprehensive of all the actors that could influence an individual's uptake and maintenance of self-care, but there are some key actors that are particularly influential, and those include partners and family members, peers and social influencers, providers, and policymakers. Next slide. Second, the degree and type of support that an individual needs is going to shift across the behavioral journey. So you'll see those actors that I just mentioned will be showing up at different times and in different ways across that behavioral journey as an individual moves through those stages and goes back and forth or skips stages. And so looking at this, starting from the awareness stage where an individual needs to understand and be aware of the self-care products and practices, to actually making that decision to practice self-care, and then actually practicing that self-care behavior or using that product, and then maintaining that practice, and then ultimately encouraging others to practice self-care based on their positive experience. And on the right here of this slide, you can see that there are a few factors that, thank you, that can facilitate self-care behaviors just for the awareness stage. These things include things like access to quality information, a supportive environment and channels for receiving information, social norms that facilitate awareness of self-care practices and products, and then also just a willingness from peers or other social influencers, partners, to share their experience and knowledge. And again, these things will change. So you may see in the awareness stage, there's a really strong importance of that enabling environment from policymakers, and then as you move on to other stages, you may see more influence of perhaps a partner or friends who support the use of a product or practice. So when designing programs or guidelines, it's really important to consider what and who is influencing self-care behavior at each of those stages. Next slide. So finally, in this framework, you will see a few factors that are uniquely important behavioral drivers for self-care. And these factors play a role in many behaviors outside of self-care, but are particularly relevant and crucial for self-care adoption and maintenance. And the most salient factors that we have discovered along this process include trust and credibility, power and equity, agency and self-efficacy, and health literacy. And Melissa is going to speak to some of these items in much more detail, so I won't go into more detail right now. We'll also explore some of these in our group work. So with that, I will go ahead and hand over to Melissa for her presentation.
Thank you, Heather. And hi, everyone. I'm Melissa Higbee. I'm the project director of DISC, which stands for Delivering Innovation in Self-Care. And this is actually our last presentation today. So I'm going to be sharing what we think are some of the project's most intriguing behavioral insights, and as much as possible, relate that to the SBC self-care framework that Heather just spoke to. So I'm going to focus mostly on themes around power, agency, and trust. Next slide, please. Thanks. A little bit about the DISC project. We're a 5-year project that's
So there might be a volume issue, Melissa. I'm not quite sure if you're connected, if we can test.
Can you hear me now?
Yes, thank you.
Okay, sorry about that. I'll be okay, so let's see. Next slide, please. Thanks. DISC's current work streams to accelerate the self-injection. Another guest. Thanks.
Sorry about that.
No worries. Totally understand. Okay, so I'm talking about our 2 work streams on the project. And the first is the development of an ecosystem. That's what we call it. You can think of it as a multi-dimensional campaign to reach women and girls in both digital spaces and real world spaces. And this is setting a foundation that we see as critical, not only for expanding access to self-injection, but also the basis of an integrated approach to self-care programs. And the second is we're tackling in a design work stream the moment of truth, that single moment when women feel confident enough to self-inject following their choice to self-inject and training on self-injection. And many women aren't feeling confident right now, so we're working intensively with both clients and providers to change that. We are now a dedicated demand generation and behavior change project, and we're working in close collaboration with service delivery partners. So that's in Nigeria and Uganda right now. Next slide, please. So Heather mentioned this, that much of the research and work on self-inject to date has focused on what's necessary to set up healthcare systems to integrate self-inject into services, feasibility and safety. I mean, that's true for self-care programming and self-inject. And there's been quite a gap in evidence around women's experiences, desires, and preferences. So in response, a DISC conducted quantitative, qualitative, and some design.
Melissa, you might have to hold your mic a little bit. You went out for a bit.
Oh, thank you. How about now?
Yes, all good.
Okay. So I was just saying that we conducted research to refine our intervention to really understand women's own perspectives, as well as how self-inject fits within the overall health system in Nigeria and Uganda. And we used a number of different methodologies, and they're outlined here on the slide. Next slide, please. So one way we've summarized our findings is along the consumer use journey. That's starting from the moment that a potential user first becomes aware of self-inject to her eventual advocacy and support for other women to self-inject. And this current journey is just rife with barriers. And through our design process, we've been solving for each of the barriers to create an ideal use journey. And I won't go there today. I'm just going to focus on what we saw in our research. So the steps of the journey include awareness, and that's the point at which the user becomes aware of self-inject and she wishes to learn more through credible, trustworthy channels. And in the case of our future self-inject client, she really doesn't hear much in her daily life about contraception and its relevance to her life, even in general terms. So if she does talk about a sexual and reproductive health topic, it would likely be with a very close and trusted source like a health provider or a friend. The next step is decision and intent. And that's the point at which the potential user has received enough information to confidently decide on whether or not to use self-inject. And for most women, this is happening because a provider suggests it as an option, and the driver of choice for her is related to discretion oftentimes. And she might go through great lengths to make sure her family or her partner don't know she's using self-inject. And given her environment, that decision feels really brave. Next, training and initiation. So she receives her first training and injection by a provider she feels will protect her privacy and provide a high quality service. And she enjoys and appreciates the training, but by the time she then has to do her next injection 3 months later, it all feels scary and uncertain again. So some women decide to go back to the provider for more support. Some manage to self-inject and feel really proud. And some don't do anything at all and just stop using the method. Then we come to continuation. So she likely gets a calendar reminder, and that works well, but disposal of the sharps is an issue. She knows that she's supposed to save it and return it to a provider, but she doesn't want to be found with it. And so sometimes she'll throw it in the pit latrine and just do whatever she needs to do to keep it a secret. And any issues she has, likely with side effects, she doesn't have many options for reliable support. And if she does manage to reach a provider, then she's often quickly reassured. And then lastly, advocacy. She finds that self-inject works well for her, but she keeps that experience mostly to herself. She'd actually really like to share, and she has plenty of ideas on how the health system could provide a better service for her, but it's not clear who would listen and whether it would be safe to speak up. So she mainly keeps her thoughts to herself. Next slide, please. So in addition to those insights along the journey, and there are many more, we identified these 7 key cross-cutting themes that are universal across target audiences and our geographies. So I'm just going to focus on those first 3 today. And we do have a full insight synthesis that's published and is coming soon. So first, around power, that's women's contraceptive choices and the way in which they inform themselves, make decisions, and act upon those decisions. Voice and agency. So women's sense of self-efficacy to take action to shape their lives and their ambitions. And then trust and credibility, or how women discern trustworthy and credible sources. And that's often linked to their perceptions of authority in healthcare. Next slide, please. So a bit more on power. Women's contraceptive use is strongly linked to their perceptions of power relative to others. And I think this has come up in other presentations as well. Overall, our findings suggest that women perceive themselves as decision makers, but they do not trust others to uphold their decision-making power. And women respondents across all of our segments, a sense of power that comes from community building. And that can happen overtly, or that could happen more covertly, secret. And then maybe more broadly, this idea of power and empowerment that has come up so much today is also mentioned very frequently in the updated WHO self-care guidelines. Someone mentioned it was like 39 times it's mentioned, but there's really no definition or conceptual framework. The evidence base that we have on the direct effects of self-care on women's empowerment, they're still really limited. So as a side note, we do have some work happening under DISC where we're at a community-based co-creation process to develop metrics around empowerment. And we're using a lot of the work that ICRW has already done in this area. Next slide, please. So here's some example imagery from our campaign that's built off the insights around power. And our messaging is all coalescing under the tagline of directly about the power and control that self-inject can offer you when it comes to my body. This image, which has really resonated well with our target audiences, and it represents this traditionally masculine form of power. And the campaign shows women taking her seat in that chair. And the next slide, please. And some more images, you see the couple are sharing the seat of power. And we know, the evidence is pretty strong that when male partners are engaged and supportive, that women are at least better able to continue use of contraception. And many women who choose self-inject are telling us that the motivation is discretion, but it's not always from their male partners. In some cases, it's actually from their extended family or their community, but having support from their partners is helpful. Next slide, please. Next slide. Thanks. Voice and agency. So we've seen that fear of the needle and lack of confidence to self-inject are big barriers to use. And we've also heard from women that organizing women to advocate through collective action may be possible. And that's particularly among women who enjoy greater freedoms at home and with their partners. And they really have expressed interest in peer started to see through prototyping that can be very effective. And then lastly, just that the act of self-injecting may be a spark for consumers' sense of power, self-efficacy, and agency. In some of our consumer research among early adopters of self-inject, we heard women saying that they felt relief. We heard them saying they were enthusiastic, they felt powerful after they did the first time they self-injected. Next slide, please. Trust and credibility. So healthcare workers really do remain the most consistently trusted source of information. And often once a trusted provider is identified, consumers will name them as that preferred channel for all stages of their contraceptive use journey. Secondly, women require an array of information from trusted sources. Women who are using self-inject covertly also want information on how they might obtain and store commodities to mitigate the risk of being found out. And information and support needs to be available not only at the point of training and initial self-injection, but particularly at that 3-month interval following training, where women really often require some additional support to self-inject the first time by themselves. And then lastly, that service providers do play this critical role in training women to be competent and confident to self-inject. And health providers currently aren't trained to coach women through fear or through self-doubt around self-inject, and many don't feel comfortable handling their clients' hesitancy, which we think is leading to this high drop-off rate among women who are initiated but never do their next self-injection. But there are a lot of exceptions to this and a lot of opportunity here where many providers, if they have support, then see the emotional support and reassurance as a critical part of their role. Next slide, please. So based on the insights from this research, and I'll just speak to our program very briefly here, because I'm at the end of my time limit, but we built a multi-dimensional campaign and a suite of digital resources to support women through their self-inject journey. And the results right now are really promising. Mostly the data we have is on the digital side, but we also have a lot of real world interventions as well. But consumer engagement is one of the key digital metrics, and we're exceeding industry baselines. And that's exciting because even this behavior of seeking sexual and reproductive health information through digital sources is to some extent a new behavior. And we are continuously optimizing our content, our messaging, our usability based on our real-time data. And we'll have better data on how this is linking to uptake of self-inject at facilities and outlets later in the year. Next slide. Yeah, so just to wrap up, for access to the full insights report, or if you're interested in partnering with us, you can find out more on our website. And that's all for me. So I'll hand it back to Sylvia. Thank you.
Yes, thank you very much, Hajra and Melissa, for sharing the conceptual framework on behavior change in self-care and insights from the DIS programs that we've just seen on how self-care influences behavior when it comes to reproductive empowerment. And to Rahin, where we have seen the importance of behavior design in informing self-care programs in a way that empowers women and also links them back to the providers. So I encourage you to keep putting your comments and questions on the chat, and we'll continue to respond to them. For now, we're going to get into breakout sessions, so please don't go away. It's getting more exciting. So we can engage a little bit more on with the panelists on their presentations. So over to the tech team for the breakout sessions.
All right, once again, if you require interpretation assistance, please simply click return to main room if you are placed in a breakout room, because the main room will have interpretation services. Otherwise, you'll be broken out into 4 separate rooms, including the main room. Room number 1 will have facilitator Rahin. Room number 2 will have Heather. Room 3 will have Melissa, and room 4 will have Alexandrina. And you'll all be taking part in a Jamboard exercise. Please, in the chat, make sure that you look at the links. You'll know which link to click once you are broken out into your rooms. Facilitators, please share your screen for the Jamboard if you so wish, and request any assistance that you may need. I'm going to go ahead and open all rooms. So, Rahin, all rooms are open, so you are welcome to begin the conversation for our main room breakout.
Has everyone clicked on the Jamboard link? And I can also try to share my screen, see if this.
To specify, we are main room, so you can click breakout room number 1, and that will be our Jamboard.
Yeah. I see some folks are already on, and let me see if I can share this with folks. I'm like a Luddite when it comes to technology. All right, can you all see my screen?
Yes, we can see. Thank you.
Yeah, so I think it'd be fun to just start off with a few questions, and feel free to note them on the sticky notes and add them. I'm hoping people are familiar with Jamboard, and you just kind of click on the sticky notes and you can add your thoughts. But what were some of the insights across the last 2 panels that kind of stood out from you? Let's start with that question and just add your thoughts, but also feel free to chat out and speak out in the group as well. Anyone have anything interesting that they thought that they'd like to share that stood out from the presentations? Or questions that they have remaining from the presentations? Yeah, so we have this importance of small details like stickers and the color of the envelope. Anything else that was eye-opening or kind of questions? There's also the next panel talked about the framework and the journey from, and there's an image of the journey. So feel free to also add in your thoughts across the other questions of like, based on some of the themes that we're seeing. Yeah, the male engagement on discs, posters, yeah. Is anyone comfortable sharing out loud some of their thoughts?
Hi, this is Megan from Chicago. I'll share like one like big question that I keep coming back to with all these presentations about empowerment is like, I think it's really important we talk about the relationship of self-care and empowerment, but I also wonder if we need to have that same conversation about self-care and desperation at the same time, or like as the other side of that coin, right? Like I was reminded this morning that when I saw a photo of a colleague injecting a woman in Afghanistan with DMPA that like self-care is not always happening from a powerful place, right? And I don't know, I just like feel like that's another element here we should be considering.
Yeah, and that's actually a very interesting aspect of, you know, thinking through what are the circumstances that people are put into as they're turning into self-care, and is the circumstance truly empowerment, or is it some other circumstance that's leading to the situation? And yeah, it goes back to this link of between self-care and empowerment, and what does that actually mean? Does anyone else have any thoughts, you know, in terms of themes that are coming up from the presentations that stood out to you? And they can be small themes or larger themes.
Yeah, I think for me, I'll say the importance of a community network, you know, to practice self-care. And, you know, that there's that question of self-care. Self-care is individual. So we understand the power of the person to make choice and, you know, empowerment and the agency. But what does self-care really means? What does self-care, you know, means to the community? And this is coming up, you know, for the second or third time in this session today.
Yeah. And if you look at the kind of the sticky notes that are coming up, it's interesting because, you know, we have self-care that's, you know, an individual action, but, you know, we have a note here of the role of self-care in providers, the importance of community. We have even the importance of male engagement, you know, and so there is an element of, you know, self-care, but there has to be engagement with other players for self-care to be effective. And so there is this, you know, to what extent is it individual and to what extent does the community need to be involved in these programs?
I think the other part that is really important in self-care, especially when it's being promoted, is it mustn't be considered so hard to do that, you know, nobody would attempt it. So I think it has to be broken down in steps and made attractive and appealing. And I think that's a big part of promoting self-care.
Yeah, it has to be designed in a way that people can actually follow through on them and understand it, and it's not daunting, the idea of it. So we have, some, I'm curious, how have some of these themes shown up in your own work in the group today, around individual versus community or making self-care programs less daunting? Is there anything that folks here could share? And if not, another question might be, some of these themes that we're seeing through this journey and the framework that was shared in the second panel of, going from awareness to making a decision and initiating, continuing that decision, how might those themes play across in each of these different stages? And I see someone has written the importance of collecting user perspectives from the outset to co-design solutions that work for them. Yeah, that's a lot more important for self-care. Are there examples specifically that anyone would like to share on stuff that they've done in terms of co-designing solutions? And then we also have continuing to pull approaches to self-care out of traditional silos and encourage a cross-examination for individuals and communities and how we can best care for ourselves and each other. Yeah. Understanding power dynamics between providers, clients, et cetera, in order to change them. What are some examples of power dynamics that have come across work from folks here?
There was an interesting reflection from Dr. Adewole on like that first panel, I think, where he shared a quote from a community member who said, it was from a man who said, oh, I don't know if this is policy that I'm allowed to do, to do whatever self-care behavior it was. Mm-hmm. And I found that really interesting, right? That this individual community member was looking for permission. And it just sort of reminded me of like, that's sort of an anthropological like basis for thinking through like, what can I do for myself, not only because I'm confident and informed, but like because I'm looking for approval or permission to be able to do that. And that was one of the dynamics I was thinking of.
Yeah. That's interesting, where it goes back to, am I even eligible to do this? And when it comes to like family planning, reproductive health with the power dynamics, it's often, in some contexts, a woman might not even think it's her decision. And so is that even something that they can do? And so who are people looking towards for kind of approval is an interesting dynamic to unpack in each of these kind of self-care situations.
Yeah, and for me, I think closely, very close to that, it's, male engagements. And I mean, this is really important because a lot of women in my country, Nigeria, still don't have the self-efficacy to make decisions. So they still want the permission from their partner, to be able to even practice self-care. So it's still a dynamic that we need to unpack and of course keep. I think again, where empowerment comes for people to even see that they can make the decision, or can they really make the decision?
And we also have a comment around pregnancy tests being an interesting example as well of self-care. Any other kind of thoughts or questions that people had as they were listening to these presentations? In the last minute, would anyone like to share anything interesting from their own work?
We have about 1 minute left.
So I do just want to read one more comment that's been added in terms of the behavioral journey. It says, I suspect that people practice more self-care behaviors, they'll become more confident in self-care and do more for themselves. But the inverse could also be true, and doesn't go well the first time, they may cease interest. And so that's an interesting insight of like the importance of first impressions. And could not designing something right backfire. Thank you all. These are very interesting insights to keep in mind. And I believe we have the links to the other Jam boards as well, so we can kind of share and see what other groups chatted about.
All right, we are closing breakout rooms and everyone will return in about 20 seconds. All right, everyone is back in the main room.
Welcome back, everybody. I do hope that you had some really engaging and insightful discussions in your breakout sessions. And I hate to say this, we're just about to wrap up. We're actually just about to wrap up on this session, as insightful as it was. I think I'd like to hear a little bit more on, we'd like to hear a little bit more on what you discussed in your breakout sessions, but what the main thing here is to try and see what it is that stood out for you, especially in this whole session. We had the first panel and we also had the next and the second panel. There's a like again to the Slido poll. Please click on the link in the chat box, and I'd like everyone to let us know what stood out for you specifically in this session. You could point to the breakout sessions in terms of the discussions that you did have, or you could point to the panel presentations during that time. But let us know what stood out for you in this particular session. So click on the link, please, and let's see how the word cloud populates. Okay. Yes, I can see, yes, the self-care lead to empowerment and vice versa. It's a non-linear path. And then it's important to have a support network when it comes to self-care. You can see the importance, same as community support, same as what has been talked about when it comes to self-care. There's a lot of, yes, empowerment, the importance of community support, the journey to self-care, especially the self-injection path. When it comes to self-injection, this points to the presentation, the DISC program. Anything else? Anything else that stood out for you? Okay, I'll give a few more minutes, a few more seconds. Okay, so what I'll say is this particular session, thank you everybody for sticking with us throughout this session. We try to make it as interactive as possible. I want to say a special thank you to the panelists and to the presenters for the great insights and presentations on this. But before I leave, let me just say what stood out and what was most dominant. And what stood out and what was most dominant in this conversation is that self-care is itself a behavior. That's something that I got from one of you as a participant during the session. But then also self-care does work. However, there's need for the following: choice, voice, and power for populations to be at the center of their own healthcare. At the same time, there's need to influence behaviors in self-care, where there's need for trust and credibility, power and equity, health literacy, and agency and self-efficacy to actually make this thrive. Giving information alone without creating an enabling environment is not enough to influence health decision-making. And this is where we talk about support from the communities. And this really talks about power and equity as well. And for self-care to thrive, a supportive system is critical. This could be a policy system, this could be a community system when it comes to decision-making and access to health services. So that's really what stood out for me during this session. And I do hope that we can continue to share insights on what stood out. I'm trying to look at the chat. Yes. So is there anyone who has something? Yes, so everyone is happy with the session. This was a wonderful session. I really enjoyed moderating this session. My name is Sylvia Mugi once again. And just to point to a few household issues, we will have the presentation recordings available. The fact that you actually attended this series on knowing thyself, we are going to have this available, and we encourage you all to share this with the networks, with your networks, so that they get to also learn from this. So Natalia, over to you for any technical announcements.
Thank you. So I will put an evaluation survey in the chat. Please enter your evaluation of the session. Your feedback is really, really appreciated. Thank you for your active participation. And that is it for today. So Lily, you can go ahead and play the closing video and we'll be done.